Okay, so welcome to Pharmacology 1, uh, where we're going to cover chapters 1 to 4. And I just want to introduce myself. My name is Dr. Greg Karagesian. Dr. Greg, or Greg, is fine. My last name's a bit long. And what we're going to do is go through the module together. And I'm just going to spend a bit of time on each slide, which is going to help consolidate your knowledge. And hopefully over the course of the entire module, you'll have a better understanding of the material, which will then help you with your tests, exams, and later in life as well. So we're gonna start here. Module 1 is not really specifically about any one drug. It's more about pharmacological processes um, and more general topics about medications um, as as a group, as opposed to getting into the specifics where we'll start to get into in module 2 and 3 and so on. Okay, so I hope you enjoy this. Listen to the material. It's not meant to memorize. It's meant for you to understand concepts, which will then help you with your testing and of course your knowledge base. Okay, so we'll start with chapter 1, and really with voiceovers, what I've tried to do in other classes is to spend 3 to 5 minutes per slide, so that you hopefully get a different perspective, maybe retain a bit more information, and bring the information more together, so it's understandable uh, for um, for other semesters moving forward. So a little bit more about myself. I'm an emergency room doctor um, working in Ontario, Canada. I've been doing voiceovers at the college for about, well, over a year now. Some curriculum reviews with the instructors, um, tutorials with students, so I'm sure I'll be meeting some of you in tutorials as the semester continues. So ask questions if you don't understand something. You can ask the instructor. You can ask me. You'll see me in some of the classes. Ask questions so that things make sense. So here's the first question to ask yourself. Why are you studying pharmacology? So the main reason for studying pharmacology is to understand is to understand medications, how medications are administered, and the effects of the medications on patients, and as well as the side effects that can occur. So you'll see that there's a process to these pharmacology classes where we'll discuss medications, their indication, so what are they used for, their mechanism of action, how do they function, how do they work, side effects and adverse effects of the medication, and as well nursing considerations about the particular medication. So moving forward, that'll be the main way that you'll be viewing drugs and studying drugs. The less memorization, the better. So the more you understand, the more you'll be able to carry forward, as opposed to straight memorizing, where it'll empty out at the end of semester, but it will still be required in upcoming semesters. So I'm here to try and help you retain some of this knowledge and put it together a bit. So what about the goals of nursing pharmacology? So definitely the first one is eliminating medication errors. And there's many ways of doing that that we'll get into later in the module. But making sure that the right medication, the right dose, the right route of administration, and of course the right patient is receiving the medication. Limiting the number of adverse drug events. So recognizing medications, recognizing their indications, recognizing when there's potential adverse drug reactions or potential interactions with other drugs that the patients are taking. For example, someone's taking a blood thinner and another blood thinner has been prescribed. That could be a potentially serious interaction with two blood thinners inadvertently being given to the same patient. So just recognizing groups of medications, their indications, and their side effects. And then, of course, ongoing lifelong learning, because medications are constantly being added, and some medications are disappearing. So there's always an ongoing, you always need an ongoing effort to maintain knowledge in pharmacology. Okay, so what's a drug or a medicine? So drug or medication we'll just use interchangeably. So it's any substance that's taken to either prevent, to cure, or to try and reduce symptoms of a condition, right? So in terms of prevention, sometimes we'll use a medication that will try and prevent a disease from even occurring. So for example, there's anti-cholesterol medications that are used to try and prevent heart attacks. There's antibiotics that are used to try and cure certain bacterial infections, such as a pneumonia. And there's certain analgesics that are used, such as opioid analgesics, that are very effective in reducing the symptom of pain. So drugs are used for a number of different reasons. Okay, pharmacology, just the study of all the different medicines. Not that it's possible to study every medicine. There's thousands and thousands of medicines, but just to get a knowledge of some of the common ones and what they are used for and the side effects of them. And pharmacotherapy is really the application of these drugs to either prevent or treat a disease. So really a nurse's role is to have knowledge of drugs that are commonly used, administration of these drugs, and remember, a lot of, even as a practicing nurse, a lot of the administration of drugs, the knowledge of drugs, it's accessible. It's not possible to remember everything. So administering, for example, an intravenous drug often needs to be looked up in a manual to see the rate of administration, what it can be mixed with, what it might interact with. Okay, so not all of this can be memorized. Assessing the effects of the drug. So you give a medication for someone's stomach ulcer. You want to assess how effective that drug has been. Do they have reduced abdominal pain? Are they able to eat better? Can they tolerate the medication? And lastly, teaching the patients about the drug that they're taking. So advising the patient on what they can expect from the medication in terms of its effectiveness, what they can potentially expect as possible side effects of the drug, what you need to monitor in them. So, for example, you're giving someone insulin for the first time. There'd be a lot of teaching around giving someone insulin. They need to monitor their blood sugars. They need to know how to administer the medication. They need to know when to contact someone if the blood sugar is too low or if it's too high. So every drug, there's always teaching around every medication. This slide is a bit of a repetition from an earlier slide, but that's fine. You really want repetition. The more repetition, the more times you see a drug, the better, because it'll finally stick. It'll stay in your long-term memory. So again, a drug or medication, prevention of a disease, treatment of a disease, cure of a disease, or sometimes just to reduce the symptoms of a condition, of a medical condition. So sometimes patients have palliative cancer, so end-stage cancer, and they're in a lot of pain. We have many medications that can help them with their symptom of pain. So whether it's a milder analgesic like acetaminophen, or an anti-inflammatory such as ibuprofen, or much stronger analgesics like the opioid group of medications, such as codeine, morphine, hydrocodone, oxycodone. So these are really the reasons why we use medications. Okay, this slide I won't spend too much time on, just to show you the vast number of brand, generic, and combination medications that are out there, each having its own side effect, interaction, and also action, what it's supposed to do. So in pharmacology, new drugs are constantly being developed. Every year, pharmaceutical companies are coming up with new drugs. Not necessarily all of them are very effective. Some are very effective. Some end up not even staying on the drug formulary. Many drugs can improve quality of life. If you have chronic pain from your lower back, controlling the symptom of chronic pain with different medications can vastly improve your quality of life. If you have depression or anxiety, there's medications that can be used to help with those symptoms, with those conditions, to alleviate some of the symptoms. On the other side of the coin, some drugs, some patients can suffer significant drug reactions that can lead to significant morbidity. So morbidity is the same as disability, or mortality, which is the same as death. So it's a really big challenge to stay current with medications, since they're constantly changing. Okay, so the characteristics of an ideal drug. So there's no such thing as an ideal drug. It's really just a drug that we think of that we'd like to have one day, but we'll never get there, because the ideal drug effectively treats or prevents or cures a patient's condition. It works very rapidly. It has no side effects and can be easily taken. So there's really no medication that fits that list perfectly. And actually, this list continues on to the next slide. So we'll talk about it there. So on top of those other ideal characteristics on the previous slide, it's also inexpensive, quickly eliminated, and doesn't have any interactions with other medications or food. this drug does not exist. But the closer a drug is to this ideal drug idea, the better it is for the patient. So a very effective drug, very few side effects, easy to take, inexpensive, and excreted easily by the body. So keep this ideal drug in mind when you go through the course, and realize that there really this idea is what you want a medication to be like, and some of it may be leaning that way, and part of it may have less than ideal characteristics. So keep this concept in mind. Okay, and just I won't spend a lot more time on the ideal drug. I think you get the idea of that the closer you get to this ideal drug state, the better the medication is. And the further away you stray from this ideal drug concept, the worse a medication is as a treatment for a patient. So in pharmacology, when we're talking about drugs, they have one drug will have three names. They're going to have the real name, the chemical name, this long molecular name that we don't use. It would be used in a research lab, but not in practice. The generic name, which is the name that has been given to that chemical, and that is the main name that you're going to use when referring to a medication. And then the brand name, which is the name that each individual pharmaceutical company has chosen as their name for the actual drug name, which is the generic name. So brand name, so one generic drug could have 10, 15, 20 brand names. So brand names are sometimes, the most common brand name might be put in brackets beside the generic name, but always know the generic name. That's the most important one. Okay, so a chemical name, what does it describe? It's the chemical composition and structure of the molecule. We won't be talking much about that. The generic name, it's the non-proprietary, meaning it wasn't given by the pharmaceutical company. It's given by an agency, so that is the absolute name of this drug, even though each individual pharmaceutical company might choose a brand name. So here's a good example. Benadryl. So Benadryl is just the brand name. The generic name, is diphenhydramine. So it's an antihistamine. That's the type of medication it is, or that's how it works in the body. It blocks histamine receptors. So it's used for allergies. It's used for allergic rashes, sneezing, allergic nasal conditions. So the generic name will always be on the box with any particular brand name, but really focus on the generic name. It's the most important. And generic drugs are typically less expensive than the brand name drugs, right? So it's kind of having a generic pair of jeans and a brand name pair of jeans. The brand name is always going to cost more, right? I'm sure you can think of many examples where the brand name of whether it's a pair of skis or whether it's a pair of shoes, it's always going to cost more than the generic pair of shoes. Well, it's the same with drugs, right? So if there's a company that's making this medication and is really just using the generic name, they're usually much less expensive. And the reason for that is many companies are making the same generic drug, so they're competing with each other, which drops the price. Now, between individual pharmaceutical companies, if the generic drug is in the pill at a certain number of milligrams, it has to be there by law, right? So to take diphenhydramine, so say it says diphenhydramine 25 milligrams, well, that's what has to be in the pill. What can change between companies are the inactive ingredients. They may be different. So even though the generic drug will be identical between different pharmaceutical companies, you can still get slight differences and different interactions from one generic drug to another, even though they're identical, because the inert, inactive ingredients may have an effect in how the drug is absorbed, or if you can tolerate it or not. So the brand name is really the name that the pharmaceutical company has chosen for that drug. And that name is restricted and given to that pharmaceutical company. And so when the drug is being developed and that pharmaceutical company chooses a name, so let's use the generic drug Ramipril. Well, what is Ramipril? It's a blood pressure medication. The brand name is Altase. So when the company was developing this drug, they chose a name. The brand name is Altase, and it stayed that way. And it was restricted to this company's. It was proprietary to the company. And then once the drug went generic, and many companies could make it, it was called Ramipril because that's the generic name by the other companies. So typically a company gets about 20 years as a patent between the time that they patent the drug, which is the development stage, to when the patent ends. And often it takes about 10 years of research and development to get the drug to market. It can be earlier or it can be later, but that's just an approximate time. So they basically have about, say anywhere from 7 to 10 years, assuming the drug gets approved by the FDA. They have about 7 to 10 years where the drug is on the market and no one else can use it. It's patented. Okay, so we won't spend too much time on this slide. It's a continuation of brand name versus generic name. And you can see that on average it can take approximately 10 years for the research and development of a drug. So that leaves approximately 10 years since there's 20 years to the patent. And after the patent has expired, then any other pharmaceutical company can produce the same generic medication. Now this slide is just giving you a comparison of the generic name, which is always just one generic name for the chemical name. So for example, aspirin is the generic name, and all the different pharmaceutical companies have chosen brand names for it. So Bufferin, Excedrin, those are all just brand names for aspirin. And the same would go for diphenhydramine, Benadryl being the most common. If you look at ibuprofen, you'll see that Advil and Motrin are there, which are very common brand names. This next slide, names of drugs. So this is using diazepam. You can see the chemical name. We're not going to be talking about chemical names very often. The generic name being diazepam. That is the most important name, since that will always be the name no matter which pharmaceutical company is producing it. The underlying name will still be diazepam. And then, of course, one of the brand names, Valium. Okay, so what about classifications of drugs? So there's different ways of classifying drugs. There's a therapeutic way, meaning let's take all the medications that we use for a certain condition and put them under one umbrella for that condition. So let me give you an example. Antihypertensives, so blood pressure medications, so to reduce blood pressure, of course. Antihypertensives is the large umbrella, and under that has many antihypertensive medications. So that's a very effective way of classifying and grouping drugs by the condition that they are used for. The other way of grouping it is by pharmacological action. So there may be 4 or 5 drugs in a group that have the same mechanism of action. And I can give you an example of this, say beta blockers. So beta blockers are a group of medications that we use to reduce blood pressure. We use them for patients with angina or with cardiac conditions. And in the group of beta blockers, they all basically have the same mechanism of action. So either can be useful. Typically, therapeutic classification is much more helpful, though. So it's nice to know all the drugs that are, say, blood thinners. So they're all grouped under the therapeutic effect of blood thinning. Or how about all the medications that are used for migraine headaches? So the condition is migraine headaches. Here's all the different types of medications. They don't have the same mechanism of action, but they're all used to treat migraine headaches. So it's just 2 different ways of classifying drugs. So here's an example of pharmacological classification, classifying drugs according to their pharmacological action, their mechanism of action. So diuretics, there might be, say, 10 grouped into that pharmacological classification of diuretics. Calcium channel blockers, say there's another 10 in that group, and they all have the same, they will have the same mechanism of action. So it's just putting drugs together that have the same mechanism of action. Therapeutic classification groups medications according to their therapies. So anticoagulants. Well, you can have many different types of anticoagulants with different mechanism of actions under this umbrella. And say, for example, some of them will inhibit platelets, such as aspirin. Others will inhibit the clotting system, such as warfarin. But they're all listed under the therapeutic classification of anticoagulants. So I find this classification more helpful. So let me give you another example. Under the heading of anti-anginals, well, so medications that can be used to treat angina. which is cardiac chest pain. Well, there's many different groups. They all have different mechanisms of action, such as beta blockers, nitroglycerin, calcium channel blockers, but they're all grouped under the anti-anginal umbrella, uh, which is more helpful, I find, when you're thinking of a condition that needs treating, seeing all the different options. Okay, so let's move on to a different topic. Drug prototype. So what's a prototype? Well, when you're thinking of drugs, prototype usually means it's one of the initial drugs in that group. So this drug has been selected to represent that group. So for example, penicillin. So penicillin G is one of the first penicillins. There's many penicillins after pen G, but we're using this as an example to represent the group. That's all. And it's often one of the first drugs that was produced in that class. So this can help you understand the group as a whole. So penicillin would be the prototype. Say there's 20 or 30 different penicillins. But if you understood the basic um, uh, mechanism of action, the indications, the side effects of the prototype drug, it can help you with other medications in that same group. So when we're talking about prototype drugs, it doesn't mean that every drug underneath the prototype within that class has all the same indications and all the same exact side effects. It's just giving you an idea of how this group of medications work and what actions and adverse effects they have. So, say for example, um, there's 10 medications in a group called ACE inhibitors, which are antihypertensives. If you knew one of the ACE inhibitors, then it definitely helps you understand all the other ACE inhibitors. So for example, ramipril is an ACE inhibitor. I'm just giving you an example here. There's captopril, there's enalapril, and they all have the same mechanism of action, the same side effects. There's minor differences between them, but understanding the prototype really does help you understand the group as a whole. So the indication of a drug is um, the 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 is what is the drug indicated for as treatment? What condition is this drug been approved for? And prescription drugs have shown some effectiveness towards treating an indicated condition. Okay, so a drug has to have at least one indicated condition, otherwise it won't be used for anything. Drugs often have multiple indications. So let me give you an example. A beta blocker, such as metoprolol. Again, you don't need to memorize this. Metoprolol is used to reduce blood pressure. It's also used to treat um, uh, angina. So that gives it at least two indications. It has other indications as well, but one drug having multiple indications is very common. The term off-label is when a healthcare provider uses a drug that's likely been around for a number of years. Uh, Healthcare providers have been comfortable with the drug for a condition that is not indicated or approved but has shown benefit. And sometimes we'll tell patients that this drug is not approved by the FDA or uh, uh, but it's been used so many times effectively for this particular condition that we suggest using it for you. So that's off-label use of a medication. This slide is really here just to remind you that pharmaceutical companies make brand names that are easily remembered. So when you're going through pharmacology, look at some of the brand names. They often have letters that are remembered by patients and healthcare providers and nurses. Letters such as Y or Z or X. So they have names that stick to you, and you recall them. That's the brand name, not necessarily the generic name. Okay, so this next slide is really the concept of substitution of medications. This will vary from state to state in terms of which medications can be substituted for another generic um, identical drug. So, for example, if a prescription for a brand name is written, if there's a substitution that's been agreed upon uh, by the government, then the pharmacist can substitute the brand name for a generic drug name. So really, the generic medications are essentially identical to the brand name medication in terms of active ingredients. What really differs is the inactive ingredients that's been put into making the pill, so the inert ingredients. And they can alter the bioavailability of two different generic drugs. So if you have diphenhydramine made from one company and made by another, they may get absorbed slightly differently because of the inert ingredients. Okay, and that'll affect bioavailability. And bioavailability is really how much of the drug that was given, say as a pill, is actually making it into your bloodstream. It gets through the intestine, it goes through the liver first, and then it gets into the bloodstream. So that's what bioavailability means. Okay, and on this next slide, in terms of before administering a medication or a drug, getting a proper history and physical, getting a past medical history of disease processes that the patient has, and then their own abilities. Can they open the pill bottle? Do they need a blister pack where the pills are packaged for them on a weekly basis? Uh, Many disease processes can be aggravated by certain drugs that are being given for another condition. So really finding out uh, the list of medications they're on, for example, the list of other conditions that they have, which could be affected by the medication, and also um, uh, getting a good history of their abilities to take the drug and remember to take the drug. Some people with dementia, of course, will not remember to take the drugs at all. Okay, and we'll go through these slides relatively quickly. This is the drug approval process, and it's in phases. So it's a process where pharmaceutical companies have to show the FDA that they have enough data and information and testing on a particular drug before it makes it to market. So phase one is a relatively small group of people, 20 to 80 volunteers, and it's really looking at are there any significant toxicities to this drug? Phase 2 is a slightly larger group of people. The focus is on how effective is this medication to treating the condition that they're testing it for. And this can take a long time in terms of finding, because for some conditions you don't know if they've improved in a week, such as some kind of an infectious process. Other more degenerative processes like Parkinson's disease, MS, we don't know for years of taking a medication whether that's been effective. And this is often controlled against placebo, right? So they're using the active drug versus a placebo drug, and they're comparing, is the drug that we're studying more effective than placebo? And placebo really just means a sugar pill. Really, there's no active drug in a placebo pill. Okay, in phase 3, a significantly larger study, hundreds to 3,000 people. And this is looking at other variables in the general population. So variability. So does the drug affect people differently? Are there significant drug-drug interactions? Still looking at safety and effectiveness from the previous phases, since there's more people in this phase, but just making sure that because people tend to be on quite a few medications, is there anything that's being missed in terms of significant drug side effects and significant drug interactions? Okay, so that's phase 3. And once passing phase 3, a new drug application can be reviewed by the FDA, looking at all the information, all the data, all the research that's gone into making the drug. And post-marketing surveillance is phase 4. So the drug has been approved through phase 3. After it gets on the market, phase 4 is looking at the medication still, accepting concerns from healthcare providers or hospitals about side effects or adverse effects they noticed about the pill. So the FDA is still acquiring a lot of information about the drug. Okay, and even once a medication is on the market, so phase 4 is to survey for harmful effects in the general population. But as more and more patients are taking this drug, potential side effects can start to declare themselves where they didn't in the approval process. So the FDA can still put a warning on a drug for healthcare providers. It can actually just remove the drug completely from the market if significant side effects are found, even once the drug has appeared on the market. Okay, just I won't spend much time on this slide. Really, this is just the reporting system that's in place once a drug is on the market, adverse event reporting system. And there's limitations to drug studies. Typically, it's not as a diverse population as the general population when you're doing a study. It's often Caucasian males that are tested more frequently. Off-label uses not regulated because the drug makes it onto the market. Healthcare providers realize that there's other uses for this drug that don't have an absolute indication. The other limitation, which I think is a good one, is that children and pregnant women are not tested through drug trials, right? So we don't get a lot of information on testing of drugs in either one of those groups. So sometimes we just have to extrapolate later once the drug is on the market and we're comfortable with it, and we find that, okay, there doesn't seem to be any harm when we give it to pregnant women or to children. So the other the other group that really isn't studied as a drug are the herbal remedies and the dietary supplements. They don't have the same rigid phases to go through. They're not considered a drug, so they're not subjected to the same process of scrutiny that the drug approval process uh, does for medications. And this next slide is really showing you the timeline of once a drug has been uh, researched and all the phases it has to go through uh, to then be approved and make it onto the market. Okay, so let's just talk about prescription versus over-the-counter drugs. And this will definitely differ from country to country. Some countries have many drugs over the counter, other ones they're more prescription based. So in general, in the United States, prescription drugs are typically ones that may be either addictive or potentially harmful when just self-administered without a prescription. Prescription drugs are often used for really complicated conditions where it's not realistic to expect a patient to manage uh, his uh, his pneumonia or his heart failure uh, by picking up over-the-counter medications. Requires some skill to administer the medications, especially when there's multiple medications. So prescription drugs are really meant to protect the population, right? So we're thinking of drugs in the opioid group, so narcotic, painkillers, sedatives, antibiotics, um, antidepressants, antipsychotic medications. So huge groups of medications are prescription. And here's some advantages of prescription medications. It definitely uh, allows the patient to go back and forth to discuss their concerns with a healthcare provider. Maximal therapy of the drug can be achieved by gradually increasing it if required, such as an antihypertensive medication. Maybe the patient started on a very low dose and it can be gradually increased um, to reach full effectiveness and control the blood pressure. It also allows for patient teaching at, say, a clinic and appropriate follow-up. So none of these things happen with an over-the-counter medication, and sometimes they don't need to. Okay, and here in terms of over-the-counter medications, don't require a prescription. Patients can treat themselves. Uh, the directions are obviously always put on the bottle in order to give direction to proper doses, and there's no monitoring by the healthcare provider. So this slide is reminding you that over-the-counter medications definitely have risk at all. There is no drug without risk. A perfect example of over-the-counter medication that has risk is Tylenol, acetaminophen. If not taken in proper doses, which would be labeled on the box, it can cause liver injury. It can cause a hepatitis. And if taken in high enough doses, it can cause liver failure. So over-the-counter medications or prescription medications both come with risk of significant side effects. Over-the-counter medications can often interact with food and herbal remedies and prescription medications. So sometimes the pharmacist is there to help out, and other times people get into trouble by thinking that over-the-counter medications really don't have any significant side effects. This slide on reclassification is just mentioning that a prescription medication can become an over-the-counter, and sometimes an over-the-counter medication can rarely become a prescription. That's much less common. Typically, it's a prescription medication that becomes an over-the-counter medication. So these are just different medications that were initially prescription, but with time on the market and time using them under the prescription model, a lot of comfort was developed, and it was decided to allow them to be over the counter. So the top left is omeprazole or Prilosec. That's for heartburn, stomach ulcers. Pepcid, again, the generic is famotidine for heartburn and ulcers as well. Sertrazine, which is Zyrtec, is a antihistamine for allergies, allergic rashes. And nicotine was definitely a prescription medication at the beginning, and now it's an over-the-counter for smoking cessation. So it's interesting to see over time which drugs become over-the-counter when they were initially prescription. Okay, so there's a schedule for certain drugs, and the schedule is for high-risk medications for dependence or abuse, and we'll see on the next slide this schedule of drugs. So the sale of these prescriptions or of these drugs and the distribution of these drugs are definitely regulated, and the drugs make it into 5 separate categories, typically based on their potential for risk of harm, dependence, and abuse. Okay, so this slide is showing you the 5 categories on the schedule. So the first category is really no prescribed drugs, like heroin, GHB, LSD. The only one that makes it in certain states is marijuana, where it can be used for medicinal purposes. So Schedule 1 is really non-medical drugs, not prescribed. So Schedule 2 are medications that are considered high risk. So you're going to think of your strong opioids, such as fentanyl, morphine, oxycodone. Another one on that list is methylphenidate, which is a stimulant medication for attention deficit disorder. Barbiturates are used, they're very strong sedatives. They're used for stopping seizures. So in this group, the ones that are prescribed, think of strong opioids, strong stimulants, and strong sedatives like barbiturates. I'm not going to go through all the different schedules. I think it's interesting just to look and see what's in them. If you go all the way down to Schedule 5, you'll see that these are pretty low risk drugs. They still have an opioid in them, such as codeine, but a bit of codeine for a cough or a bit of an opioid has been added to a medication to control diarrhea. Pretty difficult to get into trouble with those medications. So they've made it onto the schedule, but the lowest risk, which is Schedule 5. And here's the risk categories for pregnancy. And the pregnancy risks A, B, C, D, and X will be on any particular drug. So if you look at these categories, I'll just give you an idea of how I think of them. You're not going to see many Category A drugs. So in order to make a Category A drug for pregnancy in pregnant women has to be a well-controlled study in pregnant women that doesn't show any risk. And there just aren't many of those because we don't study drugs in pregnant women. So if you look at what kind of medications would make that list, it's prenatal vitamins, insulin, thyroid medication, folic acid, which is put in prenatal vitamins to protect against neural tube defects in a developing fetus. Schedule B, still, you won't see that many Schedule Bs even. Animal studies have revealed no evidence of harm to the fetus. However, there are no adequate or well-controlled studies in pregnant women. So these are drugs that have been used for many years and we're comfortable with them. And they've been given over years to pregnant women and no harm has been found. A lot of drugs make it into the Schedule C. So animal studies have shown an adverse effect and there are no adequate and well-controlled studies in pregnant women. So this would be the majority of the medications that we use. And if you just go down the list and read the interpretation, you'll just get a good idea. I think there's another slide coming up on this, but just get a good idea of the risk categories. And pregnancy X, or sorry, category X is typically a group where the drug is contraindicated in pregnancy because of injury or congenital anomalies forming. Okay, so on to chapter 3, and we're just going to continue with chatting about each slide, spending a bit of time. Not too much time because a lot of these slides at the beginning are a bit self-explanatory. If I'm repetitious, don't worry. It's good to have repetition in pharmacology. So whether it's repetition about a certain drug or repetition about processes and concepts, it's worthwhile to hear it a few times so that you keep it in your long-term memory. Okay, so now we're going to talk about routes of administration. And this slide is showing you just the different routes. So the enteral route uses the gastrointestinal system. So oral, sublingual, buccal is putting it into next to your cheek, or rectal. Parenteral is anything injectable, so subcutaneous, intradermal, IM injections, which are very common, and intravenous drugs. Topical, we'll talk about different ways of getting a topical medication into the system or to treat a local condition on the skin. So some topical medications are meant to get into the bloodstream and others are just meant to stay on the skin to treat a local condition. And then inhalational medications, vaporizers, drugs to get up into your nose, into your lungs for asthma or chronic obstructive lung disease. So just different routes. So you'll notice that there's some extra slides on the Voiceover PowerPoint, and that's okay. Some were removed for the class just because they had a bit of repetition or more repetition, but I left them in so you can see just different ways of viewing the concept. So this is just a slide showing the enteral route again, parenteral, and topical route. Okay, this slide is just showing you some potential considerations when choosing a route for a medication. So the properties of the drug, is it absorbed by the gastrointestinal tract, or do you have to give it intramuscularly since the drug isn't reliably absorbed by the small intestines? Where do you want the drug to have its effect? So if it's a rash on your arm, maybe you can just use a cream instead of a pill. The rate of absorption. So if someone is very ill, say with sepsis, which is a bacterial infection typically in the bloodstream, causing a lot of serious effects, we likely want an intravenous antibiotic to directly get into the bloodstream and be sure that it's all being absorbed. Many drugs are broken down and affected by the gastrointestinal tract and the liver, which is called first-pass metabolism. We'll talk about that in a few slides. So maybe very little of it is making it into the bloodstream. So look at these different choices and what helps you affect the choice of which route you want to choose. Okay, so bioavailability. This term came up a bit earlier, and it's really how much of the drug will make it into the bloodstream, um, depending on which route I use. That's really what it is. So, and it's dependent on the drug, right? So one medication that's given orally might be 99% absorbed through the intestines and the liver and make it into the bloodstream. Another medication, when given orally, might be barely absorbed because it's just the properties of the drug. So if we look here, intravenous, well, it's 100% bioavailable. All the drug is going directly into the bloodstream through a vein. So it's 100%. Intramuscular tends to have a very high bioavailability. So you can be assured that with an intramuscular injection, say of penicillin, most of it will make it into the bloodstream. And look and see each one. Oral has a huge difference depending on the drug. Transdermal is very high. So there's many transdermal patches that we'll talk about where when applied to the skin, the intention is to get the drug into the bloodstream. And these transdermal patches have a very high bioavailability of they've chosen the appropriate drugs that can get through the skin, and they've put them in a transdermal system, they're called, and it avoids having to go through the liver. It goes directly into the tissue and then the bloodstream, and they're quite reliable in terms of their bioavailability. Okay, so what are pharmacokinetics? So pharmaco is just the drug or medicine, and kinetics is movement. So what happens to the drug? Where is it moving to once it's been taken into the body? And that's what we're going to talk about next. So there's going to be drug absorption. Okay, so how is it getting into the body? Distribution, where does it go throughout the body? Metabolism, how is it broken down by the body? And excretion, how is it finally excreted out of the body? So these are each different categories that we'll talk about. Okay, so pharmacokinetics also we're going to be including the onset of action of a drug. So if a drug is very quickly absorbed, it may have a very fast onset of action compared to a drug that's slowly absorbed into the bloodstream, has to make it to the receptors in a certain location of the body to have its effect. It might have a slower onset of action. So we're going to talk about, okay, when can I expect this drug to start working? When can I expect its peak effect of the drug? And how long can I expect this drug to be effective before requiring another dose if needed? Okay, so that's pharmacokinetic. Pharmacodynamics is really just how does this drug work in the body? How does it affect the body? So this is a more of a detailed look at the specific drug, which is then attaching to a receptor in the body, which often is a protein molecule um, on the cell membrane surface. Uh, it's dependent upon a drug, of course. And how does that exert its effect um, in the tissues? So that's pharmacodynamics. Okay, so let's just talk about pharmacokinetics here. So movement of the drug within the body. The first process is absorption. How did the drug get in? Gastrointestinal tract, intravenously, intramuscularly. So that's just the absorption of the drug. Distribution. Where does it move within the body itself? So if it's a highly water-soluble drug, it'll tend to remain more in the bloodstream and the interstitial fluid. If it's a highly fat-soluble drug, they can typically make it into, well, your adipose tissue, your brain, uh, more commonly. So depending on what the drug's characteristics are, will affect the distribution of the drug. Like which tissues will it soak into? Metabolism refers to how is this drug altered or broken down, and this often involves the liver. So the liver is a is a is a large organ in your right upper quadrant, and it is highly involved in metabolism, including metabolism of drugs. Elimination, which is clearing the drug completely from the body, and the metabolites that have been produced uh, of the drug. And the two main organs for elimination would be kidney and liver as well. Okay, so the first slide here on absorption, just the movement from where it was administered, whether your mouth or through an intravenous line, into the bloodstream, and how was it absorbed. So depending on how it was given, will again determine how the percentage of bioavailability in the bloodstream. Okay, so if you gave a drug intravenously, you would expect that 100% of the drug would now be in the bloodstream compared to an oral medication, which may not be the case at all. So a medication such as acetaminophen, say you take a Tylenol orally, there's going to be some metabolism of Tylenol, of acetaminophen, sorry, before it actually gets into the bloodstream because it has to go through the liver. And that's what we call bioavailability of the drug, because we'll test the drug levels in the bloodstream and determine what percentage of it made it into the bloodstream. And the amount that's been metabolized as it went through the liver for this first time is called first pass metabolism. And we'll talk about that in a minute. So how much of the drug was already broken down when it first went through the liver from the gastrointestinal tract? This slide is just a reminder of different enteral routes: sublingual, oral, rectal. Just a reminder slide. So this slide is on enteral absorption. So using the gastrointestinal tract, and there's advantages and disadvantages. So definitely there's many advantages, right? You can do it, self-use at home. You can take pills. It's much easier than, say, giving an intramuscular shot or having to go somewhere for IV antibiotics. So it's much more convenient, a lot cheaper, and there's no need to sterilize anything. Um, so it's it's a very common route of administration for many medication. The disadvantages can have a slow effect, not necessarily, but it can be much slower since it has to get through the gastrointestinal tract and through your liver. Um, doesn't have complete absorption, so it will not have 100% bioavailability. It can be broken down by the pH in your stomach, the low pH in your stomach, that is, and the enzymes in the gastrointestinal tract. It can irritate your gastrointestinal tract, so many drugs are hard on the stomach. There can be interactions with food. So there's going to be all kinds of directions in terms of don't take this with food, wait for 2 hours after you've eaten. So there's a lot of food and drug interactions that can reduce the absorption of the drug. Drug-drug interactions. Some drugs can't be taken together because they're going to interact even in the gastrointestinal tract. Of course, drugs can also interact in the bloodstream as well. The first pass effect, which is what I mentioned on the slide before, where when it goes through the liver, what percentage of the drug is being broken down with the first pass through the liver. And that could affect the bioavailability. And oral medications are not useful for someone who's unconscious or vomiting, or just unable to tolerate the medication. So this is just showing you the route of where oral medications will go once they make it into the intestines. So in the small intestine, the drug will be absorbed. It will go through the portal system. So the portal system is a system of veins that drain to the liver, and most of your food, your nutrition, such as carbohydrates, lipids, protein, and drugs, will use the portal system to get to the liver. Because the liver wants to screen all the chemicals that are coming from the gastrointestinal system before letting them loose into the bloodstream. And that definitely includes drugs. Okay, so the drugs that are taken orally, which are many of them, are going to be processed and partly metabolized in the liver. And then they'll make it into the systemic circulation. So you can see there's a number of variables of what the bioavailability of the drug will be in the bloodstream. So there's the small intestine that could reduce the absorption of drug if, say, the molecule is too large. There's the liver, where the drug has been delivered. That could have a high first pass metabolism and reduce the amount of drug that's made it into the bloodstream. So this slide is giving you a very similar concept of the drug will make it through the small intestine, hopefully, get into the portal vein system, and then be delivered to the liver. Some of it will be metabolized in the liver, broken down to inactive metabolites of the drug. And then some actually within the liver can be turned around and excreted in the bile. So it never actually made it into the bloodstream. So oral administration of drugs are studied so that the correct dose can be obtained for the drug, so that we have the amount of drug required in the bloodstream to exert its effect. Okay? Because we have to take into account the first pass effect of the liver, which definitely reduces the bioavailability of the drug in the bloodstream. Okay, and this is the same concept in terms of bioavailability. Intravenous antibiotic, say for example, 100% bioavailable. Oral antibiotic, something less than 100% bioavailability, but that's still okay. because we can increase the total milligrams of the drug given orally to make sure that enough of it gets into the bloodstream. So what factors affect the rate of absorption? So orally, when we're talking about oral medication, the presence of food or fluids, something that you had to drink, that might change the absorption. The formulation of the drug, we spoke about that. So different companies have different inert components in the drug, and that might change the absorption of the same drug. The status of the small intestine. Say you have a condition of your small intestine, such as Crohn's disease or celiac disease, where you don't absorb very well. That can affect drug absorption into the bloodstream. Or say there's a problem with gastric motility, the movement and the digestive process within your intestines. Or if there's a problem with the blood flow to the intestines. Older people can have reduced blood flow to the intestines due to blockages in the arteries, which would be called atherosclerosis. That's just a term for a buildup of plaques in the arteries, and that can cause reduced flow, which would then, of course, reduce the absorption of the drug. Okay, and this slide is talking about bioavailability and first pass metabolism or first pass effect, and they definitely go hand in hand together. If you have a high first pass metabolism as drugs are going through the liver, then you're going to have a lower bioavailability since less made it into the bloodstream. Okay. Now, sublingual or buccal routes, so a pill under your tongue or a pill um, uh, between your next to your cheek, on the inside part of your cheek, they'll avoid first pass metabolism, right? So they don't have to go through the liver. They go right into the venous system, the bloodstream. So this slide is probably looking very similar in really just the concept of taking into account bioavailability in terms of giving medication orally. And remember that doses of medications are adjusted to have to account for bioavailability. So if half of your drug is metabolized as it passes through the liver um, in the process called first pass metabolism, then the drug company will have to study higher doses of the oral medication to reach proper blood levels. Okay, so you can still get to an effective drug level in the blood, but it may require higher oral doses compared to intravenous doses, which are typically lower because there is no breakdown of the drug initially. Okay, and with oral medications, there's companies have come up with controlled release forms, sustained release forms, and this just allows a drug to be broken down slowly in the gastrointestinal tract and be released slowly, so that it gives a more prolonged uh, effect and absorption of the drug, so that you don't have to be giving a medication 3 or 4 times a day, which most patients don't want to take or have to remember taking a dose that frequently. So controlled release and sustained release are really quite similar concepts, right? So the idea is that you're packaging a pill or a medication so that it's not all suddenly absorbed into the bloodstream. It's slowly absorbed and gives a reliable blood level um, uh, uh, so that you don't need to be taking the medication 3 or 4 times a day. Many tablets have an enteric coating on them. Aspirin is probably the one that comes to mind most commonly. It has an enteric coating so that it can not only mask the bitter taste, but also it protects it and allows the medication to get through the stomach and not be broken down in the stomach. So, so many drugs are coated not only to hide the taste, uh, but to also control where the medication is absorbed in the gastrointestinal tract. Because a lot of capsules need to clear the stomach and to get into the small intestine where they can be absorbed properly. So more and more drug companies are coming up with options of sublingual or buccal uh, medications, uh, routes where you don't have to depend on having to go through the liver. These easy routes have lots of blood supply going to them in the mouth, and they're directly absorbed into the bloodstream. So you just don't have to rely on what's going to happen in the liver in terms of bioavailability. Okay, the rectal route, I would say, is much less popular now since there's many other routes to give medications, such as sublingual, transdermal systems, so patches that go on the skin. So less and less the rectal route is used, but it's still a very effective way of treating a local condition of the rectum or getting a drug into the bloodstream. And there's all kinds of suppositories, enemas that can treat local conditions such as, say, inflammation of the rectum in ulcerative colitis. So you can get the solution right on the colon. We used to use anti-nauseants all the time rectally when people were vomiting to get the medication into the bloodstream to have its effect. This typically avoids the first pass metabolism since the lower part of the rectum goes into the systemic circulation. The rest of the colon typically goes into the portal circulation and does go through the liver. And of course, when you think of rectal routes of administration, um, probably the most common time we use it is for constipation. So to put in enemas or suppositories to help someone who's constipated. So the parental route usually is referring to something that's using a needle. Okay, so parenteral, so IV, IM, sub-Q, intradermal. Some of these are used much more than others. So IV and IM are used very frequently. Subcutaneous, there are some medications that we'll talk about that are subcutaneously injected, such as some of the blood thinners that we use to prevent blood clots in the leg or to treat pulmonary blood clots, blood clots that have traveled to the lung. But it's less commonly used than IV or IM. Intradermal is there aren't many intradermal medications used since it wouldn't be a predictable absorption. If you're just putting some drug under the skin, it would be unpredictable how much of it would get into the bloodstream. Okay, so so typically we're thinking of injectable type drugs when we're when we hear the term parenteral. So here's intramuscular. Now, it's not always popular to receive an intramuscular injection. Patients often don't like it, but it's a reliable way of getting muscle into the system. If it's only one injection or two injections, say, most patients tolerate it fine, but most people wouldn't want to have an intramuscular injection every 4 hours to treat their condition. So we typically wouldn't do that. That would be uncomfortable. But they are absorbed quickly because muscle has a lot of blood supply. Not as quickly as IV, but definitely much more quickly than, or much more quicker than subcutaneous or intradermal. The other advantage of intramuscular injections is that you can give quite a volume of drug compared to subcutaneous or intradermal. Intradermal, I would remember just two uses of intradermal. That's a TB skin test and allergy testing. So not many medications are given intradermal. So the drug for intramuscular gets directly into a larger muscle and then is typically rapidly absorbed into the bloodstream. Now there are special drugs that are formulated for intramuscular injection called depot drugs, and they get into the muscle and they release the drug slowly over weeks or months. So for example, there's some antipsychotic drugs for schizophrenia where a patient can come back once a month for their depot medication. They're antipsychotic as an injectable depot drug. And then they don't have to try and remember if they took their drug, or we're not worried that they're missing their doses because they've received a depot injection. Birth control pills, Depo-Provera is a birth control pill that's given every 3 months as a depot injection. And Depomedrol is a cortisone that we use in injectable form. So intramuscular can be a very useful way of delivering drugs. So intravenous medications, they're often used in critically ill patients, in patients where we're not sure about the functioning of their gastrointestinal tract. Maybe they have liver failure, or they have liver issues and we're not sure about the bioavailability of a drug that we want to give. And it's a very direct route. It goes right into the bloodstream, so the absorption is guaranteed. So someone who has a lot of nausea and vomiting, we're going to choose typically an intravenous route if we really feel they need to get a medication in quickly. Okay, we've spoken about the absorption parenterally and how it's 100% bioavailable compared to the oral route since it bypasses the liver. Remember though, an intravenous drug, you're having to puncture the skin, you're having to get into a vein, and you're having to administer a drug through that vein. So there's potential risk there. You can get a local infection where you've punctured the skin. You can irritate the vein with the drug that you're administering through it, so you can get what's called a phlebitis, local vein irritation. So it doesn't come with its own set of issues as well. But it gives you that predictable absorption and that very fast absorption into the system. Okay, so subcutaneous injections, definitely not as common as intramuscular or IV. And that's partly because that there's a bit of unreliability with subcutaneous injections. If you have cold skin, if you have low blood pressure, the tissue won't be perfused there. It won't get blood supply, so the drug won't get to the systemic circulation. And there's a necessity for small volumes of drug. You can't give large injections of subcutaneous medication. It would be painful. So it's really used for small volume injections, such as insulin for diabetes, and some blood thinners that I mentioned earlier, which are in the heparin group that are used for to thin the blood in conditions where you want to avoid a deep vein thrombosis or a pulmonary embolus, and other conditions that we'll talk about later. Okay, and here's intradermal. So a relatively rare way of administering a medication. It would definitely have unreliable bioavailability. So really this is the most common reasons for having an intradermal injection is just allergy testing to see the local skin reaction to different allergens, and then a TB skin test that many of you have probably already had uh, to see if you have a response that might indicate your exposure to tuberculosis. Okay, so on to topical medications, which come in an assortment of gels, creams, ointments, and pastes. And the reason why they come in all these different um, ways is really different types of creams are absorbed differently. So, for example, an ointment is absorbed. So, an ointment tends to be oily. It's absorbed better than a cream, and we'll talk about this at a uh, different point during this course. But so, anyways, topical medication. So they're to treat local conditions of the skin. Say, for example, you have eczema, which is a dry, uh, scaly, irritated, itchy rash. So we use topical medications to treat something like eczema or psoriasis. But we can also use topical medications to get absorbed into the bloodstream to treat uh, heart failure, to treat angina, to treat all kinds of conditions. And we access the skin as the way of getting the drug absorbed. So remember, when you're applying creams and ointments, always a good idea to wear uh, gloves. They don't have to be sterile gloves when you're just putting an ointment on someone's skin, but if you're not wearing gloves, it'll get absorbed into your skin and have its effect in you when you don't necessarily need need the cream at all. So, okay, so this slide, let's talk about topical drug delivery systems. And this is usually using the skin to get the drug into the bloodstream, not for treating a rash. A lot of creams that we use for treating the rash, they don't really get into the bloodstream that much, maybe a bit, but really the intention is to treat the local condition. So here are the advantages of a topical transdermal system, we call them. So it avoids the liver and the first pass metabolism, very easy to apply. Um, it avoids all the gastrointestinal issues like having to get through a very acidic stomach, um, having to get by all the digestive enzymes and juices of the small intestine. We can use lower doses of it because it's highly bioavailable as a transdermal system, and it can give really nice, smooth levels of drug over the span of the day. And as well, it's easy to stop the drug if there's side effects by just removing the patch or the transdermal system. So lots of advantages to a topical system. Okay, this is just another slide explaining the topical system, the delivery of a drug through the skin, whether it's for a local condition or for a systemic condition, right? So when we say systemic, we need the drug to get into the bloodstream and circulate in the bloodstream to get to have its effect in the systemic circulation. Okay, and this slide is just showing you some examples of a transdermal system. Nitrodur, well, that's nitroglycerin used for angina, and other cardiac conditions such as heart failure. And that will be delivered. So that particular patch, it's saying on it that 0.6 milligrams per hour will be delivered into the bloodstream through this patch system. The middle one is estroderm. So that's a birth control patch. Instead of having to remember taking the pill every day, there's monthly birth control patches. And the bottom one is a very strong opioid, fentanyl patches that can be applied left on for 3 days, 72 hours, and then removed, and another patch is reapplied. Okay, so typically these patches you want to avoid hairy skin or any rashes that are on the skin. The site needs to be rotated, otherwise if you're putting it on the same site of the skin, it's going to get irritated at some point. And the other thing about these drugs is that, or these systems, is that it's not like you can suddenly increase the dose suddenly. So these patches are really for fixed, reliable dosing. So I'll give you an example. Nitrodur or nitroglycerin, we can start it as a 0.4 milligram patch. And if that's not enough, if the symptoms aren't controlled, we can increase it to a 0.6 milligram patch, and so on. And the same applies to fentanyl. If the fentanyl dose isn't enough to control the pain, then a stronger fentanyl transdermal patch can be applied. Okay, and this diagram showing you a transdermal patch and how it works. And again, these transdermal patches are typically for systemic conditions. So just take a look at the diagram there. I think it's self-explanatory. And remember that the frequency of how often you have to take off this patch will depend on the drug. So a nitroglycerin patch is usually removed every 12 hours. A fentanyl patch for pain control is usually removed every 72 hours. So they differ in how often you have to remove them and then reapply another one. Okay, so topical also includes ophthalmic drops, so into the eye, and otic drops to treat ear conditions. Remember, when you put drops into the ear, they have to be a similar temperature to the body. They can't be really cold or really hot. That will activate the vestibular system and cause nausea and dizziness if they're too cold or too hot. Typically, it'll be too cold. Okay, so topical absorption, the vaginal route. So you can treat local conditions such as a vaginal yeast infection with antifungal creams or ointments. You can have systemic absorption of, say, estrogen creams, especially postmenopausally, where women are estrogen deficient. You can get estrogen into the bloodstream this way. You can have IUDs that have hormone as part of the IUD and is released into the bloodstream that way as a birth control pill. So just another route to either treat a local condition or get the medication into the bloodstream. Still on the topic of topical absorption, this is intranasal now. There's a lot of blood supply in the nose. If you've ever seen someone have a really bad nosebleed, you'll realize that. So it's a very good surface to get drugs into the system, and of course it avoids the first pass metabolism of the liver. We can treat local nasal conditions such as allergic rhinitis, which is an allergy in the nose causing congestion and edema of the tissue, so it can be treated locally with sprays, or we can get medications in for systemic effect, such as opioids. So we can spray opioids into the nose to provide pain relief, or we can spray a sedative, such as benzodiazepine, uh, into the nose to have a sedative effect. So these can be very effective, especially in children, where you don't necessarily need to put an IV in. Okay, so absorption through inhalation. Typically, this is used to get a medication into the lungs. And why would we want to get a medication into the lungs? Typically for conditions such as asthma or chronic obstructive pulmonary disease, which is a disease that's destroyed and damaged the lung tissue and creating a lot of shortness of breath, wheezing, and coughing, typically from smoking. So we use aerosolized delivery systems to get the drug into the lungs. We don't usually use the lung route to get drugs into the bloodstream. So typically, we want the drug to have an effect in the lung, and sometimes the side effects are because it gets into the bloodstream. So say an inhaler such as albuterol, which we use for asthma or COPD, it dilates the bronchial tissues. It dilates the bronchioles to allow more air in and out of the lung. As a side effect, when it gets into the bloodstream, it can speed up your heart. It can make you feel a bit jittery. It has a bit of a stimulant effect. So remember, usually the lung route is to treat local lung conditions. Okay, so this next slide you may not have on your PowerPoint for the class, but it's interesting that when you look at the metered dose inhaler. So you just have an inhaler there, you're taking it for asthma, say. Only about 10 or 20% actually gets into the lung. A lot of the medication gets deposited on the back of your throat, and then you swallow it quite a bit, unless you're using what's called a spacer or an aero chamber that's going to allow more of it to get inhaled into the lungs. A large percent of it gets into the gastrointestinal tract, where it then gets into the systemic circulation and gives you side effects or potential side effects. Okay? So remember that when someone's taking an inhaler, it doesn't mean that it can't get into the bloodstream. Okay, so so we're finished talking about absorption and the different routes of absorption. Let's just spend a slide or two on distribution. So really, distribution is where does the drug go in the body? And as I mentioned before, a lot of it just depends on the characteristics of the drug. If it's fat soluble, if it's water soluble, will determine on where it'll stay or where it will go to. So when a drug goes into the body, if we're looking at this diagram, um, there's a lot of proteins in the bloodstream, and the body doesn't like drugs just to be floating around by themselves. The body likes having control of what's being circulated in the bloodstream. So a lot of drugs are what are called protein bound. And when a drug is protein bound in the bloodstream, it is not active. It's only the unbound drug, so the free floating drug in the bloodstream, that can be active upon receptors. So one of the main proteins in the bloodstream is a protein called albumin. And albumin, along with others, absorbs a lot of the drug and holds on to it and makes it inactive. Okay, so let's look at this slide. 10 milligrams of drug is absorbed. 10% is floating unbound in the plasma. 2.5% has been absorbed into fat, fatty deposits. A lot of it is protein bound. So in the plasma, it's bound drug, so it's inactive. Some of it has gone to tissues, and then some of it will have its effect on the target tissue where you wanted the effect to take place. Okay, so this is all about distribution. Just remember, different drugs are distributed differently depending on whether they're fat or water soluble, and that when they're bound by plasma proteins, they're inactive. They're not active drugs. Okay, in this slide I won't spend too much time on. I mentioned it in the slide above about being bound by plasma proteins. And when they are bound by plasma proteins, they can't get through the albumin's a very large molecule. They can't get through the vascular membrane, and they're really bound within the intravascular space and inactive. Okay, now on top of a lot of plasma proteins such as albumin holding on to drugs and causing them to be inactive, there's also some special barriers in the body, such as the blood-brain barrier. And the blood-brain barrier tries to protect the brain from pathogens, so infections, and also it can block certain drugs from getting across. Now, because the brain is mainly a fatty tissue organ, it's made up of a lot of fat, lipid-soluble or fat-soluble drugs often have a very easy time crossing the blood-brain barrier. The other thing to consider is that if you have a lot of inflammation happening in the brain, such as with meningitis, which is a severe infection of the layers surrounding the brain, or anything else that's causing inflammation, it will cause the capillaries to be leaky and more drug can cross the membrane. Okay, so that's one special barrier. Another special barrier to consider is the fetal placental barrier. And it's not like these barriers are able to stop all harmful substances from getting across. So harmful substances can get through the blood-brain barrier, and harmful substances can get through the fetal placental barrier. So some of them are blocked, but definitely not all of them. So for example, in the fetal placental barrier, alcohol, cocaine, caffeine, many prescription drugs get across this barrier. So that's partly why we have categories of safety of drugs during pregnancy, right? So we have a good idea of whether this drug crosses the fetal placental membrane and can cause harm to the fetus. Okay, so what about metabolism now? So we're finished with distribution and where exactly can this drug circulate in the entire body, and we're on to metabolism. How is the drug broken down or metabolized into, say, for example, an inactive drug or a more soluble drug that can now be excreted by the kidneys? And sometimes the drug is metabolized into a more active form of the drug. So some drugs are given in an inactive form, as in the pill, say, and they're activated in the liver. And I'll give you an example. Codeine. So codeine is an inactive form of an opioid that in the liver is altered and changed to morphine, the active form. Okay? But typically when we think of metabolism, we're thinking of the breakdown products of the drug. And definitely the liver is the main is the main area where drugs are metabolized. So patients, for example, with liver disease or liver impairment, such as, say, cirrhosis, would need lower doses of drugs if the liver is what metabolizes that drug. So it's important to know a bit about, well, what breaks down this drug? Is it secreted directly through the kidney system and into the urine without being broken down at all? Or does it have to be broken down by the liver first and then excreted by the kidney? Because if the kidney is diseased and we know the metabolism will be slowed down, then we would give smaller doses, right? So understanding metabolism of drugs helps us decide on also the doses that are required. And as I mentioned, some drugs are excreted without any metabolism and they go directly into the urine. An example of that would be a drug called digoxin. So digoxin is typically just directly excreted into through the kidneys and into the urine. And the codeine morphine example at the bottom there, I've already mentioned. So what's going to affect metabolism of a drug in a particular patient? So definitely the age of the client. As we get older, our organs don't process and function as effectively, especially into our 70s, 80s, and 90s. Metabolism is much reduced. So first pass effect influences the amount of drug that's metabolized quickly. We've already gone over that. The specific genetics of individuals. So different individuals will metabolize drugs slightly differently. And that can have a big difference depending on the drug. Other drugs in the system. So if you are taking multiple medications, one of those medications could interfere with the liver's ability to break down the one that you're now taking. And it can cause increased levels of the drug, or it can affect it the other way and cause reduced blood levels of the new drug. Diseases of the body. So if you have kidney disease, liver disease, heart failure, difficulties with circulating the drug in the body, all kinds of diseases of the body will affect metabolism of the drug. So it's just things to consider when we're giving a drug, the effect that it can have. The picture is referring to grapefruit juice. And for some reason, ATI and it's emphasized with testing an ATI that grapefruit juice interacts with many drugs. So we'll come to that. You're going to hear grapefruit juice mentioned quite a few times, even though it's not necessarily a big factor. Not that large of a percentage of the population consume large amounts of grapefruit juice, but it is one of the juices that tends to interact with certain medications, and we'll talk about them as they come along. Okay, and lastly, elimination. How do we clear the drug from our system? And this is usually after metabolism, except in circumstances where the drug is never metabolized and it's directly excreted into your urine, for example. So any particular drug that you take will be eventually eliminated. And it just depends on the length of time that the drug remains in the system. And the main organ responsible for elimination is the kidney. But the liver definitely plays a huge role, not only in metabolism of the drug, but also excretion of certain drugs in the bile. Right? And once it's in the bile, it can be excreted into the bowel. Okay, there's definitely other less common routes of excretion of drug. Nothing compared to the kidney and the liver. You could excrete some medication through your lungs, through breast milk for sure, when breastfeeding, sweat, tears, skin, hair. They're not huge routes of drug excretion, but they do excrete a bit. As mentioned, the big ones are the kidney and the liver, right? Um, and often, in order to be excreted in the kidney, the drug has to be turned into a water-soluble type metabolite. And that's where the liver comes in, making a hydrophilic drug, a drug that likes water. Because really that's what the kidneys are filtering, right? Right? Like plasma is water soluble. If it's a lipophilic drug, well, that can be excreted in the liver because the liver produces bile. And bile emulsifies fat. Like fat can live within bile. So fat-soluble drugs are often metabolized and excreted in the liver. Sorry. Okay, another concept that's important to know is the half-life of a drug. So when given a drug, how long does it take for the body to metabolize and eliminate half of the drug? So different drugs will have different half-lives. Certain drugs, when given, when injected into the body, might have half-life of seconds. They break down really quickly. Another drug may take days to break down and reach 50% of its original amount. So this concept is important to know that, say for example, someone's taking a medication that has a very short half-life. Well, once they stop taking it, it's going to wear off very quickly compared to someone who's taking a drug that has a long half-life, that once they stop taking it, they can still have high drug levels for many days to weeks afterwards. Okay, so long versus short half-life, it's important to know this concept. The other side of the coin is like a drug that has a longer half-life will take longer to build up to serum levels that are effective and longer to wear off. Short half-life will quickly reach proper serum levels and then wear off extremely quickly. And I gave an example at the bottom of a drug called adenosine. It's used for a cardiac arrhythmia. Don't worry about that right now. And it lasts 10 seconds compared to fluoxetine, which is Prozac, and that has a half-life of about 5 days. So it'll be at 50% at around 5 days in the serum. So that's the half-life of a drug. Okay, so another concept that we're going to talk about is loading dose of a drug versus maintenance dose of a drug. So because some drugs, as we mentioned on the slide before, can take a long time to reach therapeutic levels in the bloodstream because they have a long half-life, and they take a long time to wear off as well with a long half-life. A loading dose is to get the medication at a therapeutic level in the bloodstream so that you don't have to wait days and days for a dose to build up gradually in the bloodstream. So a loading dose is a much higher dose as the initial dose to prime the system, to increase the blood serum levels, and then switching to a maintenance dose that keeps the concentration of the drug at a therapeutic level in the bloodstream. Okay? So really the goal of this is really just to get to a therapeutic range faster with a loading dose and then maintain someone on a maintenance dose to keep them there. Okay, so we're just going to talk a bit about pharmacodynamics. We did mention the term earlier in this module, and it's really about a ligand. You could see it as even a drug, for example. A drug could be a ligand, and its effect on different types of receptors. So if the drug is an agonist for the receptor, meaning it acts basically the same as um, the ligand that's naturally produced in the body, then it's going to have a full agonist effect, whatever that effect was in the cell. So if the effect was a uh, was positive with the ligand, and now you're using an agonist drug, which is going to behave identically to the ligand, you'll have a full agonist effect. So you could have a full positive effect if that's what the ligand did naturally, or a full negative effect within the cell, which is what the ligand did naturally. A partial agonist effect, meaning it works a bit like the natural ligand, but the drug only partially stimulates or inhibits the receptor, just like the ligand would have fully stimulated the receptor. This particular drug has partial agonistic effects. And an antagonist is basically a blocker of the receptor. So sometimes we'll use drugs that have antagonistic effects, and they block the natural ligand from attaching to the receptor. So there's full agonist effects, meaning it's going to behave just like the natural ligand or the natural chemical. Partial agonistic effects, it'll partially behave like the ligand, but just not as strong or positively or negatively. And then a full blocker, an antagonist. Okay, so pharmacodynamics is really the study of the biochemical and physiological effects of the drug. What's it going to do at the receptor? Is it going to be an agonist at the receptor or an antagonist at the receptor? Is it going to have stimulatory effects at the receptor or inhibitory effects at the receptor? And then to examine the body's response. Okay, so really it involves studying receptor binding and then the receptor effects. Once the drug has bound to the receptor, what happens? And it just helps with understanding pharmacodynamics will help you understand the effects and side effects at the receptor level of what's going to happen in the body. Okay, so let me give you an example. Epinephrine. So epinephrine as an injection is used, say, for an allergic reaction, a severe allergic reaction, say anaphylaxis. We'll talk more about this in the next module. So epinephrine is an agonist on certain receptors in the body. So it stimulates certain receptors, so it's a full agonist. Just like epinephrine that's floating around in your bloodstream, injectable epinephrine would have the same effect, the full agonist effect. Whereas there's calcium channels in your body that use calcium to operate, and we have drugs called calcium channel blockers. They would be antagonist to those channels. They would block those channels. So we'll talk. The concept of an agonist and an antagonist will make more sense as we talk more about different drugs. What about potency and efficacy? So let's talk about each one separately, and then we'll come back and see which one's more important. So the potency of the drug, of a drug, is how much of the drug do I need to give to have a therapeutic effect? So if I have a highly potent drug that requires a tiny dose in terms of milligrams to reach a therapeutic effect, that's a highly potent drug. Okay, so for example, morphine and hydromorphone. So hydromorphone is much stronger than morphine. So about 1 milligram of hydromorphone which is an opioid, is equivalent to about 7 milligrams of morphine. So it's much more potent. Okay. Does it mean that one has more efficacy than the other? So efficacy means how effective is the drug to treating a particular condition. And this matters much more. Does it really matter that I give 1 milligram of hydromorphone versus 7 milligrams of morphine to reach the same effect? No, the potency doesn't matter that much. I can give more or I can give less. It's how effective is the drug towards the condition or illness that really matters. So I would much rather take a medication that has a high efficacy than anything to do with potency. So sometimes people will ask, is this a really potent antibiotic? And I don't really know how to answer that question. So potency is just based on the dosing of the antibiotic. Like, here's the dose I'm giving. Whereas if someone says to me, how effective is this drug? Then I can tell them clearly, well, this antibiotic is highly effective for your strep throat, say, for example. So to continue, efficacy is the bigger, is of much greater importance, knowing how effective the drug is. Okay, so the dosing is not as important because we can raise the dose to get to the proper efficacy. So when comparing two drugs, one might be much more potent than the other. One might require a smaller dose in terms of milligrams, but if they're both equally efficacious, that's what really matters. So if it takes 10 milligrams of one drug to have the same effectiveness as 1 milligram of a different drug, that's okay. They're both effective against the condition. Okay, so this slide is just the concept of the drug response curve. So this is referring to the amount of drug that you have in the system versus the effect or the response. And you can see that for any particular drug, I mean, this is a general slide, but for any particular drug, the response will go up as the dose goes up, and then it'll plateau, meaning you won't get any more response no matter how much more drug you take. And an example of this would be, say, taking acetaminophen for a headache. Often people will come in and say, I have a really bad headache, so I took 4 extra strength Tylenol, which happens to be 2,000 milligrams. And typically Tylenol or acetaminophen is dosed at 1,000 milligrams per dose for an adult, and 4 times a day, so up to 4 grams a day in 24 hours. So if you take 2 more acetaminophen or 2 more of any particular drug, and you've already reached your maximum response, it's not going to be any more effective. In fact, you're going to get more of the side effects and adverse effects versus any more effectiveness. So often we'll tell patients, taking this particular drug beyond this dose will not have more of a positive effect for you. You'll just get more side effects. Okay, so that's the dose response curve. Okay, so the next slide are still more concepts. We're just talking. I know I've been talking about medications and drugs and giving examples. It's only because you're going to see them again. So the more you hear about a drug or you hear something about a medication, the better it is, I think, for you to understand it and then have it stay in your long-term memory for longer. Okay, so the onset of action. It's always nice to know the onset of action of a drug. If someone receives a medication, you can also reliably tell them this medication is going to start being effective in the next whatever, 1 hour or 2 hours. So say someone comes in with a broken arm and you're giving them intravenous morphine, you can reliably tell them that typically in the next 10 to 15 minutes, you're going to notice a therapeutic response. So onset of action is a very helpful concept. The drug's peak effect is how long will it take for it to reach the maximum effect of this drug. So let's talk about insulin. So insulin, rapid acting insulin. So there's different types of insulins. There's long acting insulin, there's rapid acting insulin, and there's some in between. This is just to give you an example. Rapid acting insulin will start to work in 20 to 30 minutes, and it's going to peak very quickly, typically in the first hour. Well, that's important to know because your blood sugar is going to drop very quickly within that hour. So you should be having a meal with rapid acting insulin. Whereas long acting insulin may take 10, 12 hours to even start being to reach its peak effect or to reach its maximum therapeutic effect. So it's not like you have to take a meal right after taking an injection of long-acting insulin. Okay, so that's just an example. What are peak and trough levels? So these are blood tests. They're serum levels that we take for certain medications, typically medications that we really want to know the drug level in the blood because we want to avoid toxicity of the drug. So most drugs we don't take peak and trough levels of, but certain drugs we do. So the peak is typically the peak dose or the peak level is the highest level that the drug gets to in your blood, in your serum. And that could be taken, say, an hour after a dose of the drug. A trough level is the lowest level that it gets to in the blood. And that's usually taken about 30 minutes before your next dose to get a good idea of what's the lowest level it gets to in the blood before the next dose. And some examples of these are aminoglycosides, which are a type of antibiotic that if you get toxic levels in the bloodstream, it can harm the kidney and also harm the ears. And vancomycin, another antibiotic that can also harm the kidneys and harm the ears in toxic doses. There's other medications that we do peak and trough levels on to really monitor the serum levels of the drug, just because of their potential toxicity. So the duration of action of a drug is really how long is this drug going to work until I need another dose. And that's partly why we have controlled release and sustained release drugs that are given orally, so that it can be taken, say, once or twice a day, so that it will last until the next day. The duration will last until the next day. This is also important to know in terms of dosing. Say someone's post-op, they've had their appendix removed and they have pain. Well, it's a good idea to know how long is morphine going to last, or what's the duration of IV morphine or oral morphine, to know when you can expect the patient to require another dose. Okay, so duration of action is important. Therapeutic index. What's the safety margin of this drug? So when does the drug start to be effective? And when does the drug, as it climbs in the serum level, when does it start to become toxic? So if you have a very wide therapeutic index or a very large therapeutic index, it means that there's a big distance in the therapeutic level between when it starts to work and when it becomes toxic. If there's a very narrow or low therapeutic index, it means the serum level of when this drug becomes effective and when it becomes lethal or toxic is very close together. So those tend to be less popular drugs because you can easily overshoot the dose of a medication and go from an effective level to a toxic level. Okay, and that's the concept of therapeutic index. And here's a nice slide of therapeutic index. So the check mark is showing the serum concentration of the drug, of where it generates its effect. So its effectiveness level begins there. And then the triangle, the hazard triangle, is saying this is the level where the drug is going to start to become toxic to many patients. And the level in between is the therapeutic index, where you like to see your drug level. Okay? And sometimes we'll just take a drug level, not a peak and a trough, but just one single drug level to see where we are in on the spectrum between below the therapeutic index, in the therapeutic index, or above it. A drug such as phenytoin, which is a seizure medication, an anti-seizure medication. If someone comes in and they're taking phenytoin and they've had another seizure, well, sometimes we'll take a phenytoin serum level to see where they are in their therapeutic window. Are they below the threshold of being effective? Are they in the therapeutic window, or are they above it? Okay, so sometimes we'll just take one level of a drug and not necessarily a peak and trough, just to see where we are in terms of the drug levels. But remember the concept of therapeutic index. So a very narrow therapeutic index means the level at which the drug is effective and the level at which it becomes toxic are very close together. Not a great drug. Another example of that will be theophylline, which is used for asthma and COPD, which has a very narrow therapeutic window. Wide therapeutic window gives you a much larger safety margin. The serum concentration at where it's effective and where it becomes toxic is very wide, so much more comfort in using the drug. Okay, so here's a nice diagram just showing you the peak level of a drug versus the trough level of a drug. So on the left, there's an initial dose of an antibiotic, and usually you want to wait at least 3 doses of any particular drug before you start doing peak and trough levels. You wouldn't do it on the first dose of a drug because it hasn't reached maintenance levels in the blood. So usually it's the third dosing that we're doing peak and trough levels on, such as an aminoglycoside or vancomycin. Okay, and usually after the third dose, you'll get a peak level about an hour to an hour and a half after giving the medication. So that's your peak. And the trough level is the lowest that it goes down to in the serum, and that's usually, that blood test is usually taken 30 minutes before the next dose. So you get a peak and a trough level for this particular drug. Okay, so just the concept of peak and trough again. On the x-axis is time. On the y-axis is the serum concentration of the drug, whichever one we're talking about, whether it's vancomycin or aminoglycosides. So it's just showing you that depending on when the dose is given, you will reach a peak level, and then in between doses, you'll reach a trough level, and so on and so on. And we will check peak and trough levels with toxic drugs to make sure that we're staying within the proper dosing and the proper serum concentration. Okay, and as I mentioned before, there's some drugs that we just take one single level on, such as digoxin, which is used to help the heart pump, or phenytoin, which is to stop seizures or to control seizure episodes, and carbamazepine, which is another anti-seizure medication. Okay? Remember, I'm just showing you these drugs as examples. I'm not asking you or suggesting that you memorize the drugs because you will see them again in other modules, and that's not what this module is for. But the more you see it, the better it is for you later. Okay? So this slide looks busy, but it's actually a very useful slide. It puts a lot of the concepts that we've been talking about into one slide. So on the lower left, there's the administration of the drug, whoever that is, whether it's IV, oral, whichever route that was chosen. And then there's the concept of onset of action. How long will it take for the onset of action to occur? And then there's the full absorption of the drug that reaches a peak level in the serum. The drug then gets distributed throughout the whole body, so the peak level is now going to drop because it's distributing throughout the whole body. And then elimination of the drug through either the liver or the kidneys, and the drug will gradually drop in serum concentration. Okay. There's a toxic level at the top, 20 in this case. There's a therapeutic range of where the drug is effective. And then there's what's called a minimum effective concentration, meaning once you drop below this level, the drug will have next to no effects in the body. So the minimal effective concentration. And you can see that along the x-axis at number 10, it's saying termination of action, meaning you've gone below the minimal effective concentration. So there's no action of the drug any longer. It's lost. It's until the next dose can get it into the therapeutic range or index again. Okay, so it's a very useless, it's a very useful slide to give you a good understanding of the different concepts that we've been talking about. Okay, so some more terminology. We're almost at the end here. As I mentioned, I'm trying to keep each slide, each module to about 2 hours and 15 minutes. Some will be a bit shorter, some will be a bit longer. Hopefully you enjoy them. Let me know, or let your instructor know, if there's anything you'd like to see changed with the voiceovers, or if they're very useful to you or they're not useful to you. If my voice is coming through clearly, if I'm talking too fast, anything, just give us some ideas or some feedback. Okay, so pharmacotherapeutics. So pharmaco, drug, therapeutics, therapies, different types of drug therapies. So supplemental. So this supplies the body with a substance needed to maintain normal function. So these are usually vitamins or minerals that you can purchase. They're supplemental therapies. They're in addition to, say, your diet, or in addition to other prescription medications. So when we say supplemental, we usually mean vitamins or minerals. Palliative therapy is typically a therapy that's used for patients that are at a stage where comfort is the most important. That is the goal. So keeping the patient comfortable. So that's palliative therapy or palliation. Supportive therapy is maintaining. Let me go back to palliative therapy for a minute. So say someone has chronic pain from their cancer. A goal of palliative therapy would be to control their pain effectively with different medications. Okay? Sorry about that. Supportive therapy is more maintaining the body function while a patient is recovering from an illness or a trauma. And that might be something like intravenous fluids for someone with a severe burn that is unable to eat at the moment because they're so ill, or someone who's unconscious and requires intravenous therapies to support them while they while they're trying to recover. So prophylactic therapy, what's that? So prophylactic therapy is really a therapy or a drug therapy to prevent something from happening. So there's no actual illness right now or condition. You're taking a drug to prevent it from happening. And there's some prophylactic therapies that aren't that effective, and there's others that are effective. So let me give you an example. Taking daily aspirin, ASA, acetylsalicylic acid, to prevent a stroke. Yeah, would be an example. So aspirin thins your blood a bit by inhibiting the platelets, and it can prevent uh, ischemic or thrombotic, meaning strokes. So a type of stroke where the blood vessel clots up on itself can be prevented by taking daily aspirin. Or taking one of the cholesterol lowering medications to prevent another heart attack. So say you had a heart attack 5 years ago and you started on one of the cholesterol medications such as atorvastatin, which is Lipitor, to lower your serum cholesterol levels to try and prevent another heart attack in the future. Okay? Another example would be taking a dose of an antibiotic if you have a heart murmur or a mechanical valve prior to having a dental procedure. So when you have a dental procedure, some bacteria always gets into the bloodstream. And for most of us, that's fine. Our body can get rid of it. But if you have something metal in your body, such as a mechanical valve, or if you have a heart murmur from a previous damaged valve, the bacteria can stick on to those areas and cause an infection, which can be serious in the case of a heart valve infection or a valvular infection from previous scarring of the valve that now has bacteria on it. So dentists will often give a prophylactic dose of an antibiotic if those conditions are known that you have a mechanical valve. Okay, so that's prophylaxis. So avoiding the illness with a medication. Okay, second to last slide here. Therapeutic index we spoke about. Tolerance is the concept of decreasing response to a drug when given at the same dose. So let me give you an example. Opioids are a good example of this. So someone is taking 10 milligrams of morphine for their pain. And over the span of months, assuming that their condition hasn't worsened and is causing more pain, just say assume their condition is staying the same and it's creating the same amount of pain, but the morphine is not as effective as it used to be at the beginning of taking it. That's tolerance. It means that the body is becoming accustomed to this dose of morphine or this dose of the drug, and it requires escalating doses of the drug to have the same effect. Okay, so that's tolerance. Okay, what about dependence? So a physical dependence or a psychological dependence on a drug. A physical or physiological dependence means that when you stop the drug, you're going to have a physiological response to the withdrawal of the drug. So for example, if you stopped a sedative drug, such as a benzodiazepine, which is an example of, say, diazepam or lorazepam. If you've been taking a sedative for months, the physiological effect of when you stop it is that you might get sweaty, you might get nervous, or your heart will be racing. You may have diarrhea now because your whole body is withdrawing from this sedative drug that you were taking. A psychological dependence is when you stop a drug and it creates more cognitive effects, such as you're now much more nervous off the medication. So anxiety is being created by removing the drug. So a perfect example of another physiological dependence is when someone tries to stop taking an opioid and they have sweating and nausea and they're pale and they have abdominal pain and they have diarrhea and their heart's racing and they're vomiting and they're withdrawing from an opioid. And they have a very strong craving to take another dose to correct all of these symptoms. Okay? So physical dependence is the physiological need for a drug to stop the withdrawal symptoms from happening. Okay, so the withdrawal symptoms can be so uncomfortable that you want to take another dose to stop them from occurring. Okay, so this is a complete repetition of a slide that was in the module that I left in this voiceover. The agonistic effect of a drug. So a drug that activates a receptor and produces the same response as what was affecting the receptor in the body. So the natural substance, the ligand. Okay, so that's an agonistic effect, and we have many drugs that have agonistic effects. Meaning I want to mimic a naturally occurring chemical in the bloodstream, such as epinephrine here. Antagonistic effect is a drug that blocks the biological response. So it's binding to the receptor, for example, and blocking the response that the body is trying to do. Okay, and examples of those are beta blockers and calcium channel blockers. They antagonize the response at the receptor. They block the naturally occurring substance of affecting the receptor. Okay, so I hope this helps. Remember, the concepts are what are most important, not the tiny details. It's the big concepts that you can take forward and apply them as the semesters go on. And as well, the testing is often on the large concepts to make sure that you understand them so that when we start talking about drugs and drug actions, you'll understand what an agonist effect is, or what a therapeutic index is, or how the drug is metabolized. Okay, so I hope you enjoyed this module. Again, please give feedback. It's always helpful when doing these voiceovers to adjust my way of doing it if it's all helpful. Okay, see you next time. Bye bye.